Tell me about your MS and right from the top, if you could.
Okay, well, it started in, well, I'm not sure what year it started, but I was having trouble walking. I would be golfing on the golf course or curling, and my left knee would just completely collapse on me. I would fall down, or and I just couldn't hold my weight up.
And what about what year was that sort of going on?
That was actually started a long time before, probably. It could have been as early as maybe 94,
Okay.
that I was noticing a problem
Okay.
walking.
Okay, go on.
And so in 1997, I went to my doctor and told him I was having real difficulty walking. So he sent me to a orthopedic surgeon, where I had arthroscopic surgery on my left knee. And of course it took a while to recover from the surgery. But I still wasn't walking properly, so I went through physiotherapy to try to strengthen the knee. And I still wasn't walking properly, so this went on for a couple of years, and finally I was laid off from work in 2002.
And you work for
Canadian Airlines.
Okay.
And I went to my doctor, and I told him, look, I said, something is still not right. I'm not walking properly. I want you to find out what the problem is. So he referred me back to my orthopedic surgeon, the one that had done the surgery on my knee. And the orthopedic surgeon said, it looks like it's a nerve problem. He said, I'm going to refer you to a neurologist. The first neurologist I went to said he was baffled. He said one test showed one thing, one test showed another thing. So he referred me to another neurologist at Vancouver General Hospital, where they did an MRI, something called visually evoked potentials, and somatosensory evoked potentials, which checks the response of your brain, the time that it takes for your brain and your muscles to react to kind of like an electric shock almost. And after those tests, and the neurologist watched me walk, and finally I was told, you have MS. And then I was referred to the MS clinic at UBC Hospital, and I've been seeing them.
When you were first diagnosed with MS, what year was that?
In 2002.
2002. Okay. All right. Anything more you want to add on that?
No, I think that's
okay.
it.
Let's just look at how you are right now. Then let's start with your left arm.
Well, I have trouble straightening my fingers, as you can see. My fingers are straighter on my right hand than on my left, because I can't straighten them any more than that in my left hand. I can lift my arm, but it's difficult.
Very good. Okay.
Backwards, that really hurts.
Okay.
The right arm works better. I can.
It looks good. Yeah.
Pretty good mobility there.
Right. Okay.
And when I had an ultrasound and an MRV, that's an MRI that concentrates on the veins, it showed that the jugular vein on my left side is completely collapsed, which probably explains why my mobility is less on my left side than on my right. The right side is partially collapsed.
And that is something that you had to pay for at the Vancouver, what was it, the clinic?
Falls Creek Surgical Center.
Falls Creek Surgical Center. Okay. So your strength in your left hand is very weak.
Yes.
Like left.
Okay. And my
Okay.
left leg, I cannot move at all.
Okay. Your left leg, no movement at all. Can you move your toes at all? Your left?
No.
No.
Nothing.
How about your right? Can you?
On my right side, I can move my toes a little bit.
Okay. Okay. Let's just see what kind of movement you have. Okay. So.
I can move the ankle a little bit, and I can, well, if I put my foot down,
So you can move your toes a little bit on your right side,
Yes, they are.
but there's nothing at all on your left.
Nothing at all. I can't move
Is
left
the
leg at all.
so is the strength gone right from your hip down? Is it, Caroline, or
Pretty much, yeah.
hip down? Okay.
Yeah,
And
because I can't lift the leg at all from the hip.
okay, so
like,
there's
like what I can do is I can brace myself, and no, I can't even do that.
okay, all right, okay. Well, that's great. So now today's date is October the 3rd or 4th. Is it today?
It's the 3rd today.
3rd today. Okay, it's October 3rd, and we're going to go to California and see. The procedure is called.
It's called the Liberation Treatment for a condition called chronic cerebrospinal venous insufficiency, CCSVI for short.
Okay.
And that is a condition that they've determined is the veins blocked in your jugular vein and in your neck and your zygos vein in your chest. This was discovered by Dr. Paolo Zamboni, Ferrara, Italy.
Okay,
He's
great.
presented a paper for this.
Okay, we're going to document your progress as of today. Today was sort of the starting point, and we're going to see how you progress through this whole thing. And this is just to document and just to see how things work out. Okay, very good. Thank you. Here we go.
Dr. Arata said that I'm a classic case of CCSVI. He believes that it's not the veins that are the problem, it's more the valves that are the base of the neck that limit the blood flow and cause the veins to collapse. So what he's going to do is he's going to insert an angioplasty balloon and try to get the valve to open up and to stay open. He believes that that will cause the blood to flow normally the way it should be.
And if not, then he will put stents in.
He will put in a stent.
If required, but unlikely.
He said it's very unlikely. He said he has not had to put in stents. He said he was able to do the procedure without. So that's what he said he's going to do with me.
Okay, and we're all very hopeful for this, aren't we?
We are very hopeful, yes.
Okay, great. Thanks. And what's today's date? I forgot to put that in.
Today's date is Tuesday, October the 5th, 2010.
And it's 10 o'clock, and you're going to go for your surgery when?
I have a pre-op at 10:30. The procedure will take place at 11 o'clock.
Perfect.
Not really. So I'll kind of just go through the procedure like we sort of talked about.
Really quick. I don't want to take up your time,
It's
sir.
good to do anyway. So
Okay.
what we're going to be doing is we're going to bring you into the room and get you sterilely prepared. We're going to give you some sedating medicines to make you comfortable. We'll enter the vein in your groin, the femoral vein, with it's called a sheath. It's just a plastic tube, fancy IV like you have in your arm. Okay. Mm-hmm. From there, we will search out for the veins that are involved with CCSVI and take X-ray pictures of them by using the catheter to inject X-ray dye. It's an iodine salt water. Okay. We'll be looking for the abnormal valves, which are seen in patients with CCSVI. If we find that they are indeed abnormal, which I have every reason to suspect they are based on what you've told me about yourself and seen in prior imaging, we'll then use techniques to disrupt the valve. Most commonly, it's just a balloon to tear it. Okay. The vast majority of the time, that's all that's required. Sometimes we have to do additional measures, but the vast majority is just the balloon, and it literally disrupts the valve. When we do that, it takes about an hour or so for the procedure. Most patients feel like a stretching sensation, not necessarily pain. The risks, as I mentioned yesterday, are very, very low. Bleeding, infection, allergic reaction to contrast, or injury to the vessel, all can occur and are very unlikely. Afterwards, we'll just watch you for a little while, make sure that there's no problems, and then just ask that you rest for the rest of the day, which almost every patient, you don't have to ask that just happens. Okay?
Right.
All right.
Okay, great.
Anything come up?
No, you were so thorough yesterday.
Okay.
Covered
Everything was
Great.
addressed. Good.
Yep.
Good. All right. So we'll get started.
Okay.
We dilated both jugular veins. The left side was very tight.
Yeah.
The right not so much. But we, like I
Yeah,
think
that's
you
what the
mentioned.
ultrasound showed too.
Yeah.
There's the left vein.
So the flow now is going through your jugular veins, not going through any collaterals, and it's very brisk, rapid flow, which is great. We did have an interesting finding that I don't believe is associated with CCSVI, and that's that the iliac vein on your left side is compressed to the point where it almost disappears on the venogram.
Oh.
And
What is that vein?
well, that's the vein in your pelvis, the iliac vein on the left side. It actually, anatomically, it is underneath the right iliac artery because it's you know, the two vessels split into a Y. And in order to cross from left to right, one of them has to overlie the other. And it turns out the right iliac artery overlies the left iliac vein. Okay. And the way I kind of like to describe it is the artery is a lead pipe, and the vein is a garden hose. And if you put a lead pipe on top of a garden hose is going to get flattened.
Right.
Okay. Most patients, it's not that significant in terms of how much blockage, and doesn't cause any, you know, ill effects to the patient. There are some patients where that blockage is quite severe. In your case, the vein literally disappears on the venogram. It's completely flattened, and the flow actually is being diverted around it instead of going, you know, north to the heart like it should.
Right.
It goes across to the right to the other side, and then it goes up the lumbar veins to the azygos system. And that's why it's potentially important that this finding exists in patients with CCSVI, is that if there's increased pressure into the azygos system because it's blocked here, and then it's got more blood going through it because of the blockage in the iliac, it could make it worse.
Oh.
Your azygos is fine, so the good news is that's not a problem.
Yeah.
But the question is the blockage here in the iliac causing you any harm? And we actually didn't talk about, I normally talk about this with patients before, but we didn't discuss this. So
Yeah.
patients who have this anatomic finding will either have a history of DVT blood clots in the left leg, which you didn't mention.
No, I never did. My dad did.
Okay. You often will have a heavy, tired sensation in the left leg.
That was one of the first things when I was diagnosed with MS. Is the left leg felt very heavy at times. Felt like I had lead weights around my ankles.
Yeah. Okay. Well, that is a very typical complaint or symptom that you will see with this what's called May-Turner syndrome. That's the acronym.
Oh, I've heard of that.
Yeah.
Yeah, they say some people that have that May-Turner, they figure that could be confused with CCSVI.
Exactly. Confused is the key point.
Yeah.
It's not that it's related. It's that it could make someone with CCSVI that has a blockage in the azygos worse if they also had this blockage. Okay. So in addition to that heaviness, you will see patients have sometimes swelling in the left leg, but a normal right leg. Okay. Or you'll have patients who have varicose veins in the left leg, but a normal right leg. Okay. So those are the kinds of things we can see as a result of this blockage of the iliac vein, this May-Turner syndrome. So it sounds like, at least in the past, you had that heavy feeling in your left leg, and that's probably because of this.
Oh.
And it's something that you should be able to get addressed at home.
Oh, okay.
I mean, this is a known entity. It's been around for decades. The treatment is to stent it. It works very well. It's very safe, minimally invasive treatment that really should be something that your healthcare system should cover.
Great. Oh, thank you for that.
So it'll be in my note, and then we'll also have the pictures. It's a pretty dramatic picture, so it'll be...
Yeah, it's something they can't say, well, maybe...
It's hard to argue this picture, because you just see the vein like a nice pipe, and then all of a sudden it's just gone, and everything's going around it.
Wow.
Okay.
Thank you for that.
You're
wow.
welcome.
Dr. Arata, could that have anything to do with the like bladder control or anything like that down there? No?
Probably not.
Not no.
No.
Okay.
No, it's basically unilateral symptoms involving the left leg that
Okay.
So it's lower.
out of proportion to what we would see on the right side.
Okay.
It's not uncommon that patients with MS, because of the calf muscle atrophy and loss of tone, get swelling in the legs. Okay, so the calf